The proportion of common, less common, and rare cancer is shown. Common versus rare cancer occur almost identically in half, but rare cancers are further divided into less common and rare cancer with 27 and 20% respectively. Of these 20%, every third patient has a very rare form of malignancy. On the right side of the slide, 5-year survival of patients with rare and common cancers classified into age groups is shown. It is clearly seen that rare forms have significant lower survival at all ages. And on this slide, the survival of patients is marked, but respectively through 1 year, 3 year, and 5-year survival. Compared to frequent gynecological malignancies, it is clear that rare diseases have a lower survival, which is most pronounced in the 5-year survival. The incidence and prevalence of rare gynecological malignancies are shown here, and the 5-year survival is specifically indicated, but now according to a specific malignant disease with appropriate histopathology. The shortest survival is observed in mixed epithelial mesenchymal tumors of the ovary, and trophoblastic tumors have the longest survival. This presentation briefly addressed the current state of management and the lack of effective treatment strategies for some of the most commonly observed rare gynecological malignancies. There are 5 main types of gynecological cancers that affect the female reproductive system and genitals, including cervical, uterine, ovarian, including fallopian tube, vulva, and vagina. Of these, less common forms of gynecological cancer include vulvar, vaginal, and fallopian tube. The cervix, uterus, and ovaries are not considered rare or unusual when they are affected by the most common histological types typical of that location. But if an unusual histological type develops in them, they can be further categorized into rare form of cancer. For example, squamous cell carcinoma of the cervix versus neuroendocrine carcinoma. Some of the rare histological types that can occur in general in the female genital system are shown here. In the following slides, I will show the histopathologies in the corresponding genital organs. If we talk specifically about ovarian rare malignancies, there are usually germ cell and sex cord tumors, but there are many other histopathologies such as invasive borderline tumor, mucinous and clear cell carcinoma, sarcoma, carcinosarcoma, small cell tumors. Ovarian metastases from primary carcinoma of the breast, endometrium, or cancer of the digestive tract are also rare ovarian malignancies. Sarcomatose histopathological types such as leiomyosarcoma, stromal sarcoma, adenosarcoma, or less commonly angiosarcoma, liposarcoma occur in the endometrium. Also, carcinosarcoma, serous, and clear cell carcinomas can appear in it. If we talk about cervical cancer, it is a very common malignant disease with the most common histopathology being squamous cell carcinoma. But squamous cell subtypes can classify the disease into rare forms, such are papillary squamotransitional carcinoma, sarcomatoid carcinoma. Glandular tumors include adenocarcinomas, mucinous forms, and other listed. Carcinoids, small cell carcinoma, as well as sarcomas can also be verified less frequently in the cervix. About 10% of the total gynecological malignancies occur in the vulva and vagina, which are considered rare neoplasms due to their localization. Among them, squamous cell carcinoma is the most common with a frequency of 90%. The remaining 10% are melanoma, sarcoma, basal cell carcinoma with a low incidence of 2 to 4%. Gestational trophoblastic neoplasia is rare, affecting about 1 in every 100,000 pregnant women. Statistically, it appears rarely, under 1% of gynecological malignancies. There are several types of gestational trophoblastic neoplasia like choriocarcinoma, invasive mole, placental site trophoblastic tumor, epithelioid trophoblastic tumor. Germ cell and sex cord stromal tumors comprising less than 15% of ovarian cancer combined. First, about the germ cell tumors, which are listed on the slide. Standard first-line treatment is based on management principles as in male germ cell tumors and epithelial ovarian cancers. It is surgery and chemotherapy based on platinum preparation such as cisplatin in combination with bleomycin and etoposide. An alternative could be carboplatin and a different number of chemotherapy lines depending on the extension of the disease and the general condition of the patient, of course. With this slide, I want to emphasize the similarity in the oncological treatment of different types of germ cell tumors between dysgerminoma, immature teratoma, and yolk sac tumor. But also the similarity with platinum-based treatment as in epithelial cancer, from which the limitation in treatment can be concluded. Ovarian sex cord stromal tumors are a group of neoplasms that develop from the sex cord, like Sertoli cell tumor, granulosa cell tumor, or stromal cell, fibroma, tecoma, Leydig cell tumor, or both Sertoli Leydig cell tumor. The combination of bleomycin, etoposide, and platinum, as well as the second combination of carboplatin with paclitaxel, are the two basic standard therapeutic combinations with a high level of evidence according to the latest recommendation. They are common to granulosa cell tumors as well as Sertoli Leydig cell tumors. It is also noted that they are applied in almost all stages of the disease, in the early stages if bad prognostic factors are present, and in the advanced stages they are the basic treatment. The main problems are: we cannot deny standard chemotherapy, but clinical practice shows that additional and strictly specific treatment is needed, especially in the second, third, and further lines of treatment during relapse of the disease. It requires long-term treatment with increased expression of side effects, with each subsequent line and disturbance of the patient's general condition. Especially considering that recurrent disease currently has a very poor prognosis. The presented possible solution from improving treatment are conclusions from the latest European update on rare cancers. There is a clear need for new innovative drugs that will enrich the standard chemotherapy line, be it in the first line or in relapse of the disease. New research is expected to define new molecular factors which will enrich the systemic treatment approach. As I said at the beginning, collaboration and multidisciplinary approach are very important for better education and motivation. Malignant neoplasm of the vulva and vagina are rare malignancies, both according to location and histopathological types. Histopathologically, squamous cell carcinoma is the most common, but extremely rare forms include basaloid tumors, forms melanoma, and Paget's disease. In the last 30 years, significant progress has been made in the management of vulvar cancers towards a more conservative surgical approach. Wide of radical local excision is recommended. Vulvectomy may be required in cases with multifocal invasion arising on a background of extensive vulvar dermatosis. All tumors larger than 2 cm require pathologic inguinofemoral lymph node evaluation. The goal of excision is to obtain tumor-free pathological margins. Surgical excision margins of at least 1 cm are advised. Due to the rarity of vulvar cancer, especially advanced disease, prospective randomized trials on adjuvant therapy are extremely limited. Adjuvant external beam radiotherapy is the option of choice when there are positive resection margins postoperatively or close surgical margin, or to treat the pelvic and regional lymph nodes and or to prevent local recurrences. Adjuvant radiotherapy should start as soon as possible, preferably within 6 weeks of surgical treatment. In locally advanced or inoperable forms, radiosensitizing chemotherapy is recommended like definitive treatment. Chemotherapy is based on platinum preparation, preferably with weekly cisplatin or carboplatin. Given the rarity of primary vulvar cancer, data on the treatment of recurrences are even rarer and there is no clear standard of care. The treatment approach and patient outcome depend on the site and extent of recurrent disease. Isolated local recurrences can often be successfully treated with radical local excision and or re-irradiation plus chemotherapy. When talking about metastatic disease and the need for systemic therapy, it must also be noted that there are no standard regimes of systemic therapy for treatment. The basis is platinum preparation, but the other listed are also used. Biomarker-targeted therapies are a new class of treatment. They may be beneficial in patients with advanced recurrent or metastatic cancer. Many tumors, including vulvar cancer, are known to overexpress PD-L1, which disrupts PD-1 function, which disturb the antitumoral activity of T cells. It is estimated that 10 to 50% of vulvar carcinomas express PD-L1. Therefore, PD-L1 inhibitors like pembrolizumab would be beneficial in vulvar cancer patients. Melanoma can have a vulvar or vaginal presentation. The therapeutic approach in resectable forms begins with vulvectomy or local excision of the vagina with adequate margins that are recommended for melanoma. Given the radioresistance of melanoma, radiotherapy techniques, percutaneous radiotherapy or brachytherapy, have a palliative purpose. Systemic therapy is based on standard chemotherapy, but with more and more frequent attempts at targeted therapy through the inclusion of these patients in clinical studies. Primary localized cancer of the vagina have radiotherapy as the most important treatment. It is being improved with new radiotherapy techniques, mainly to spare the organ at risk. It can be a standalone treatment, percutaneous and brachytherapy, or with competitive chemotherapy with a platinum preparation, cisplatin or carboplatin, when the FX increases. Only in selected cases, mainly early stage disease, are they treated surgically. And cervical cancer can be classified into rare malignancies with the indicated histopathological types. All these forms are clinically different from the most common squamous cell carcinoma with the aggressiveness of the disease, resistance to treatment, worse prognosis, more frequent relapses. But despite that, the treatment is common. Surgery in the early operable stages with subsequent oncological treatment. Inoperable cases are treated with percutaneous radiotherapy, sensitized with chemotherapy, uterovaginal brachytherapy application, chemotherapy mainly with platinum drugs. Advanced stages, recurrent and metastatic disease, in addition to locoregional treatment, also require systemic therapy. Taxane, cytostatic, and platinum are predominant here and are usually combined as polycytostatic therapy. In order to improve efficiency, immunotherapy with bevacizumab is also included, monoclonal antibody which inhibits tumor growth by inhibiting tumor pathological vascularization, and pembrolizumab, an antibody that blocks PD-L1 receptors in cases where their presence will be confirmed, or in cases with confirmed microsatellite instability high and or deficient mismatch repair. Where is the problem? The answer is complex. It is clear that there are therapeutic options, but it is clear that they are insufficiently effective. Clinical practice show the most common equalization of the treatments of the different histopathologies accordingly to the organ of primary origins of the disease. Lack of highly specific treatments that will match the biological behavior of the disease. Well-designed treatment options are often insufficient and limited due to: in the local control of the disease, the biggest problem is the limitation of the radiotherapy load on the target region. due to the tolerability of the organ at risk. The problem is recurrent disease where local treatments, surgery and radiotherapy have been exhausted. In the case of systemic disease, there is a constant need for many lines of chemotherapy, which leads to the development of a chemoresistant disease, mostly to platinum preparation, which have been clearly proven to be the most effective in gynecological oncology. With other chemotherapeutics, there are maximum doses that must not be exceeded due to the expression of their side effects. In example, cardiotoxicity, nephrotoxicity, etc. The development of the disease and previous uses therapies, previous comorbidity, reduced the general condition of the patient, which is another clinical problem in their treatment. Rare gynecological malignancies are specific in themselves, without strictly defined treatment, which is why recurrent and metastatic disease is a global health problem. This group of patients is without a well-designed and effective strategic treatment. Personalized medicine, which includes targeted therapies, is currently emerging as a solution to this health problem. Rare diseases need new clinically relevant data, which would be a treatment goal with the possibility of avoiding the previously mentioned problems of standard oncology therapy. Malignant cells are a complex organized system which includes proliferative signaling, evading growth suppressors, resistant to self-death, replicative immortality, induction of angiogenesis, and activation of invasion and metastasis. They are characterized by genome instability and avoidance of immune destruction. Therefore, the solution for a modern approach are in the molecular structure of the tumor, the discovery of biomarkers which will offer anti-tumor effects through different mechanisms of action. Tumor suppressor genes which control the cell during cell division, suppression of oncogenes, genes that cause cell growth, disabling of tumor growth through inhibition of tumor pathological vascularization. Innovative personalized medicine is based on a good knowledge of all of these characteristics. Thank you.
He has very clearly outlined all the problems related to rare gynecological malignancies in a very well done presentation. So now it's my pleasure to invite Professor Irina Tripak from the Institute of Oncology of Moldova, and Professor Tripak. So she's one of the original MC members of COST, like under the previous chairmanship. So she has stuck it through for the 4 years, and we hope to continue working together. She's going to be presenting her lecture on endometrial cancer, which is the work of her PhD, and her second PhD, very
because
important.
in our country we have 2 PhDs.
Exactly,
yes.
Exactly. And she's going to be describing the clinical morphology and the molecular genetic aspect of endometrial cancer. So the floor is yours.
Yeah.
Thank you.
Thank you, Professor Jean. Dear colleagues, I'm very honored to participate in the training school of rare cancer and gynecology. My topic is endometrial cancer. It's a rather common disease in female cancer, but in spite of this, I have some data also on rare gynecological cancer during my presentation. I'm a surgeon in the Department of Gynecology at the Institute of Oncology of Moldova. Also, I have a research in the laboratory of biology of cancer. Endometrial cancer is, as I said, is the 6th most common cancer in females. Sorry. It's okay? is the sixth most common cancer in females. Roughly about 382,000 new cases are diagnosed each year in worldwide, and endometrial cancer accounts for 90,000 deaths worldwide. The estimated 5-year survival rate in developed countries is about 80%, with primary treatment consisting of combinations of surgery, radiotherapy, and adjuvant chemotherapy. Median age at uterine cancer diagnosis is 62 years. Endometrial cancer in Europe. The number of new endometrial carcinoma cases in Europe in 2021 was about 134, with 41,000 of deaths, and the incidence has been rising with aging and increased obesity of the population. As we know, endometrial cancer is traditionally classified in two pathogenic types. The classification by Bachmann, which was elaborated in 1983. The first type is most often associated with good prognosis, while type 2 is associated with a poor prognosis. This dualistic model doesn't fully capture the wide range of clinical, genetic, and molecular characteristics found in endometrial cancers. The adequacy of risk stratification system in endometrial cancer have recently been compared and challenged. There are 5 major risk stratification systems, of which the modified ESMO classification was demonstrated to best discriminate for recurrence and nodal metastasis in apparent early-stage disease. As we see, low, intermediate, high advanced, and metastatic risk group. Considering the high number of possible biomarkers, only a few have been included in internationally recommended guidelines for risk stratification. However, none of the existing schemes were deemed highly accurate. In addition, all current systems stratify women based on pathologic data obtained after surgery staging. Stage is a component of risk assignment. There is a great need to obtain earlier and more biologically informative data from endometrial cancer tumor that could assist in planning the optimal course of treatment for the patient. The modern molecular classification is Tumor Cancer Genome Atlas classification, which divide endometrial cancer in 4 groups. The first group is ultramutated group. The hallmark are mutation in the exonuclease domain of Pol. The second group is a hypermutated group, which tumors that harbor a high rate of mutation resulting from impaired DNA MMRI pathway. The third group is copy number low, and copy number high is the last group. Also, the Leiden Transportec and Vancouver Promise pragmatic molecular classification systems incorporate the same integral components, and it includes mismatch repair deficiency or microsatellite instability, also Pol exonuclease domain mutation, and aberration of p53. Prognostic strength of molecular classification is at least equivalent to other clinical pathological features of risk stratification systems, but offers the advantage of objective results. Microsatellite instability, as we know, it's a highly conserved mechanism used to restore DNA integrity after the occurrence of mismatching errors. And the 4 genes that play a critical role in this process include MLH1, MSH2, MSH6, and PMS2. It's a condition of genetic hypermutability resulting from defective DNA MMR. A tumor that accumulates thousands of mutations, particularly clustered in microsatellites and consisting in repeat length alteration, resulting in microsatellite instability. And it's important to assess microsatellite instability status in endometrial cancer, and ESMO consensus guidelines recommend immunohistochemical testing using the antibodies against the 4 proteins listed above: MLH1, MSH2, MSH6, and PMS2. In the event of indeterminate, the immunohistochemical findings, molecular testing with microsatellite instability PCR is recommended using one of 2 panels assessing microsatellite markers, where MSI is defined as loss of stability in 2 or 5 markers. Our study, which we performed in the Institute of Oncology, was a prospective study. It was approved by our local national ethics committee, and it was prospective data of 269 patients with endometrial cancer who had undergone primary surgical treatment between 2018 and 2021. The inclusion criteria were as follows. Patients were diagnosed with stage 1-2 endometrial cancer, and patients had a complete case record, including age, body mass index, comorbidities such as hypertension and diabetes, surgical procedure, pathological results, histotype, death of myometrial invasion, cervical stromal invasion, and also we performed immunohistochemical marker Ki67, and also we performed molecular testing for determination of PTEN and MLH1. The exclusion criteria were as follows. The patient didn't follow the surgical treatment, patient with other malignancies, and patients who received chemotherapy or radiotherapy before the surgery. And we divided the patients in 4 groups: low-risk group, intermediate group, intermediate high-risk group, and high-risk group. At the first stage, we performed the study of clinical morphological features, as I said, histological subtype, the histological aspect of differentiation, invasion in myometrium, tumor size, growth form, invasion perilymphovascular, perineural invasion, and the second stage was the studying of the molecular features and immunohistochemistry characteristics of the tumor. And in the final of the study, we performed a multifactorial analysis of the set of the established prognostic criteria with estimation of the predictive value for each separate criteria. So these are the results. The distribution of the patients with endometrial cancer according to the risk groups in the contiguity with the pathological type. We had the most common was, of course, endometrial adenocarcinoma, and we have 3 rare cancer: uterine cancer as serous adenocarcinoma, clear cell adenocarcinoma, and mucinous adenocarcinoma. The high rate of this rare cancer we observed in the high-risk group. The dependence of Ki67 index expression on the tumor grade in patients with endometrial cancer. As we know, Ki67, it's a marker of cellular proliferation, and it is increasingly being used in pre-surgical studies in endometrial cancer as a primary outcome measure. Unlike in breast cancer, however, there are no guidelines standardizing its measurement and its clinical relevance as a response biomarker is undetermined. The level of Ki67 expression estimated in our patient showed that the index more than 49 was related to deep myometrial invasion and poorly differentiated types. The proportion of MLH1 promoter methylation among the patients with endometrial cancer stage 1-2 from different risk groups, acquired mismatch repair deficiency resulting in microsatellite instability is a diagnostic phenotype for multiple cancer types and especially for colorectal cancer. Either germline mutations in the key genes as described for the Lynch syndrome or somatic mutation can result in microsatellite instability tumors. The group of MMR counts about 36% of endometrial cancer, while only 2% of endometrial cancer are associated with Lynch syndrome. MLH1 promoter was detected in 50 patients with endometrial carcinoma in stages 1-2. The proportion of patients under 50 years onset was significantly higher, and endometrial type carcinoma accounted for more than 80% in each group. High rate of MLH1 promoter methylation also was observed in the patients with endometrial cancer from high-risk group. The pathogenic features of MLH1 is shown in table. The proportion of G1, G2 was significantly lower than that of other groups, and the proportion of G3, G4 was significantly higher in patients from the high-risk group. What was very interesting that we find and we identified these mutations in 2 patients with well-differentiated adenocarcinoma, 2 patients from the low-risk group. The alteration of PTEN gene occurs about 45% of endometrial cancer and is more commonly found in endometrial cancer than in other histological subtypes. PTEN was detected in 50 patients. High rate of PTEN, about 32%, was observed in the patients from the high-risk group. The pathogenic features of PTEN we see in the table. Also, the proportion of G1 was 0, and it was significantly lower than in the other groups. And also I could mention that I identify one case of PTEN mutation in a patient with well-differentiated adenocarcinoma from intermediate risk group. Despite its generally favorable prognosis of primary diagnosis, recurrence of endometrial cancer remains an important clinical challenge. We classified recurrences in 4 groups: locoregional recurrences, abdominal recurrences, and distant recurrences, according to the first type of recurrence. Locoregional recurrences included vaginal and pelvic recurrences. Distant recurrences included lung, liver, bone, and brain metastasis, as well as lymph node involvement other than pelvic or para-aortic, and mixed recurrences as recurrences with multiple dissemination pathways. In total, we had 15 recurrences. 3 patients experienced local recurrence, 6 patients regional, 2 distant, and 4 patients mixed recurrence. The level of Ki67 is a prognostic factor for prediction of overall survival. And here we see the results of the expression of Ki67 in the immunohistochemical examination in 50 patients. Was imposed by its predictive value on survival, so that with its increase, the survival rate, overall survival, decrease. In patients with Ki67 level close to proliferative activity, about 49%, the survival rate was 80.8%. And with a proliferative activity more than 98, the survival rate decreased till 57.9. During the 3-year surveillance period, we had a little surveillance period, just 3 years. The analysis of the obtained results showed that the patients with the presence of MLH1 epimutation significantly affects also overall survivals, regardless of the risk group stratification. The mean time to progression in patients with this mutation was about 14.6 months. And the dynamic observation of the patients with obtained positive tumors during the 3 years, also regardless of the risk group, we revealed a poor prognosis of the disease, which was manifested either by recurrence of adenocarcinoma or by the appearance of metastasis in 4 cases. In the conclusion, I would like to say that our study was performed on the group of 269 patients, and it revealed clinical morphological predictors of the recurrences, as presence of rare uterine cancer, as clear cell carcinoma, glandular squamous cell carcinoma, serous papillary cancer with invasion more than 50% in myometrium. The depth of tumor invasion in myometrium was more than 1 centimeter, and in the stroma more than 0.5 centimeter. The presence of lymphovascular invasion and the presence of necrosis in the tumor. The level of Ki67 expression estimated in the examination of 50 patients was imposed by its predictive value on survival. So with its increase, the survival rate decreased, and the level close to proliferative activity between 0 and 49, the survival rate was about 80.8, and with a proliferative activity that was more than 49, the survival rate decreased during the 3-year follow-up period. DNA testing in 50 patients with endometrial cancer detected mutations in the MLH1 gene in 10 cases, and is to be used to determine the risk of the disease recurrence. The analysis of the obtained results showed that the endometrial cancer patients, the presence of MLH1 epimutation significantly affects overall survival, regardless of the risk group stratification. The mutation of obtained gene was detected in 12 patients. The 3-year follow-up of these patients shows the appearance of the recurrence of endometrial carcinoma in 8 cases and the appearance of metastasis in 4 cases. Research based on the clinical, morphological, and genetic studies revealed new pathogenetic mechanism and predictors of endometrial cancer, such as the presence of TIN gene mutation, promoter methylation, proliferation marker Ki67, which allowed us to develop a mathematical model for predicting of the evolution of the disease in the patients from different risk group through the 3-year follow-up period. That's all.
Extremely good. Thank you.
Thank you very much.
Irina, you've really done a lot of work, okay, which I'm sure you'll manage to make multiple publications out of this extensive work. And although endometrial cancer, I mean, as you said, is overall a common cancer, but for sure...
Anyway, we have data about the rare
exactly,
cancer also.
Exactly, and especially when it happens in younger women, and which unfortunately, is happening. I mean, it's still considered rare. I mean, so not only the typical postmenopausal ladies, but even in young women who still have a period. So thank you so much. Are there any questions for Dr. Irina, Professor Irina? No? And I don't see any questions in the chat, so thank you so much. So it is now my pleasure to introduce Professor Istok Takac. I hope I said the name correctly. So I know that he is online already with us. And, yes, you can hear us already. We can see you. So you are co-host, Professor. So if you wish to share your screen, yes, well done. And so Professor Takac, he is joining us from the University Medical Center in Maribor in Slovenia. And again, that goes to show how international this training school is. And we're going to be hearing about the individualized approaches in endometrial cancer and an opportunity for better management. So it will tie in with what Professor Irina has been telling us. Thank you so much.
Good afternoon and greetings from Maribor, Slovenia to all participants, and especially would like to thank all the Writing Committee and Professor Kaleja Hamils for this introduction, and of course I would like to congratulate also Professor Topolsky for all efforts for this exceptional meeting. My topic is, as Mr. Chairwoman already said, individualized approach in some rare endometrial carcinomas. And as Professor Lina Pipa already said, endometrial cancer is one of the most frequent cancers in women. In Slovenia, for example, as we can see in the right-hand side of this slide, it is on the fifth position among all women cancers. And of course, besides typical and the most frequent one, which is endometrioid, we have also several non-endometrioid cancers, and they are at about in frequency of 10. To local regions like Anexa and to come in hereditary manner, and these are mainly due to mismatch or repair deficiency genes.
Sorry, Professor. Sorry to interrupt. Is it possible to just press a bit on the shares the slideshow, just because they're appearing a little bit small. Just to press on the slideshow, if that's okay, so we can see them a little bit bigger in the room. That's all. No, it's okay. There is a little window at the bottom for the slideshow, or else from above. Sorry for interrupting.
He says I'm sharing.
Because he's on share.
I'm sorry, I'm very sorry.
No worries. You can proceed, because I think you'd have to.
I will check this. Just give me a second.
Where does it press? F5. I think if you press F5,
Do you see now the slide, the first one?
No.
Can you share your screen? Show him. Hello. Okay, so you can share your screen, I guess. We will stop sharing now Professor's screen. Just, do you have any PowerPoint here open?
No, I don't have Office. This is serious. I think you managed. Yes, you managed.
Yeah, you did.
You managed. Well done. Yes. Sorry for interrupting, but we were missing a little bit of the detail in your slides, and we didn't want to miss any. So yes, now we can see the whole screen.
You can see now my first slide.
There's the first slide. Yes, now.
I got the slide.
Yes. So you can proceed from where you left. But we can see the full screen now, so really thank you.
Now you can see this is the second slide.
Yes, we can see.
And then we have incidence growing.
Exactly. Yes.
And on the right-hand side is classical endometrial adenocarcinoma invasive component, and of course 5 years why I already explained.
Perfect. Yes. You can continue from here. Thank you so much.
I'm sorry.
No worries at all. Thank you.